Hello, and welcome to a very special podcast that is part of a series I'm leading on diversity and inclusivity with CME Outfitters. Today's CMEO briefcase is entitled Addressing Racial Disparities in Orthopedic Care. I'm Dr. Monica Peak, and I'm a professor of medicine at the University of Chicago. I'd now like to welcome Dr. Melvin Harrington. Dr. Harrington, I'm honored to have you joining us today. I'm looking forward to the discussion.
It's a pleasure for me to join you today.
Great. Let me start with our first learning objective, which is to assess factors for disparities in arthroplasty or replacement procedures. But before we begin, let's start by asking you, the audience, this question. Healthcare disparities in total knee replacement procedures include which of the following? First, Black patients have postoperative complications at a rate that is 2.5 times higher compared to white patients. Number two, patients from minority groups have 4 times more arthroplasty procedures than white patients. Number three, Black and Native American patients have higher rates of procedure-related mortality or death than white patients. Number four, Hispanic patients have worse outcomes compared to other racial and ethnic populations. And then number five, I have no idea. I'm not sure. So I'll give you guys a few minutes to answer the questions. We have options 1 through 5. And these are tough questions, all reasonable. Okay, so what we see, the answer is, the correct answer is that Black and Native American patients have higher rates of procedure-related mortality than white patients. And so that answer was not the most populous answer, but we had a lot of good options to choose from. What do you think about this response?
So I think if you look at the other choices, the data looking at the complication rates being slightly higher in underrepresented groups is correct. Those numbers probably aren't the true, don't show the true magnitude, but there is a higher incidence of postoperative complications and mortality among African Americans and Native American groups following surgery, and so it's an issue that we do need to address and deal with.
Great. So Dr. Harrington, from the data, we know that even after we adjust for patient-related factors and healthcare system-related factors, the rates for orthopedic surgery, such as knee replacement surgery, are often lower for patients in underserved populations, yet adverse outcomes are more likely to happen. And so what are some of the reasons for these underlying disparities?
Well, it's really multifactorial. There are sort of patient systemic related issues, patient-related issues, and provider-related issues that can lead to disparities, ranging from potential access to care issues, variations in the quality of the institutions and providers at those institutions. And then there's a lot of simple patient choice and why some patients may or may not be more or less likely to elect to proceed with joint replacement.
Right. Well, we know that surgical care involves a really complex interplay of factors that begins with screening and diagnosis and ends with post-op care and rehabilitation. What inequities can occur along this whole trajectory that lead to disparate surgical joint procedures and care?
Yeah, so, the first, again, begins at sort of the systemic institutional level in terms of which facilities do patients have access to. Do our underserved populations have access to the surgery centers, which is now where there is a huge push for our total joints to be done. And then, throw on top of that the social determinants of health of, are our patients even able to do a same-day outpatient procedure? Do they have the resources at home and support at home to be able to provide that care, as opposed to needing inpatient care? Other patient factors that come into play are medical comorbidities. We currently focus quite a bit on medical optimization of our patients. And so there's a move not to operate on obese patients. We make sure we don't operate on smokers. We need to make sure that diabetes is well controlled. And sometimes these optimization criteria can end up eliminating patients who may have higher incidence of comorbidities, which tends to occur in our underserved communities. So those are just some preoperative things that can happen. Perioperative, again, it depends on where you are and the quality of the institution, and what are the institutional results in terms of outcomes. And then post-operatively, again, it comes down to access and social determinants of health, and being able to go home versus to a skilled nursing facility, for example. There's great data showing that patients who are discharged to a skilled nursing facility have higher readmission rates and higher complications than those who are able to go home. So all of these issues have to be addressed.
Absolutely. I'm going to take one question. We have so much to get through today. I'm going to try and make sure that we have enough time at the end to have a robust conversation. But one of the questions that has already come up as surgeons, I know that you guys are really, you people, not just guys and women, are focused on the technical aspects and making sure that you are really doing your best in the surgical theater. But one of the questions was, how do you know when someone is getting disparate care? When you are primarily, it's you and your team in the OR. How are you aware of what else happening in other ORs and what you may inadvertently be doing? How do you understand about the population of disparate care that your patients may be experiencing on a global level?
That's challenging as an individual provider. I try to work within my team to, eliminate as many of those issues as possible, and then, within my department and hopefully institutionally. But I truly don't have control over, what goes on in my partner's clinic. I try to do education within our department on health disparities and things like that, so that my colleagues are aware of implicit bias and, providing culturally appropriate or cultural humility, and trying to address those. But it's really challenging. It also comes into play in terms of different practice groups and what insurances they may or may not take, and those systemic factors which are really almost beyond the control of us as individual physicians and surgeons.
There's a colleague of mine who looked at internal medicine practices and found that while physicians were pretty accepting of the idea that disparities in care existed in our country, they're much less likely to say they existed within their group practice, and then certainly not within their own patients. But of course, disparities have to occur someplace, and if every doctor didn't have them, then where were they occurring? And so sometimes, it takes a good hard look at our own data. And so I think that looking at guidelines and having the institutions where we work be able to accurately collect data by race and ethnicity for processes of care and outcomes of care, and then being able to share that information with providers and in a transparent, let's all grow together way, I think can also be helpful, rather than putting that onus on the individual providers to try and go around and do that detective work. But this is something that as a profession, we're all sort of learning together how to figure out how to get our hands around these issues. But I think one of the best ways that we can illustrate these structural issues, as well as the interpersonal inequities in care in general, as well as orthopedic care, is to look at the needs of some of the individual patients. So let's do that now. Let's look at a patient case. But once again, before we discuss the best orthopedic care for the patients, we're going to do another audience response question. So this question is, what is a primary factor in functional health outcomes after a total knee arthroplasty procedure? So number one, the type of arthroplasty device used. Number two, a delay in the necessary orthopedic surgery intervention. Number three, the gender of the patient. Number four, biological differences in patients. And number five, I don't know, or I'm not sure. So we're going to give the audience a few minutes to answer. And we'll see what kind of responses we come up with. All right. 63% responded in delay in necessary orthopedic surgery intervention, and that was the correct answer. So excellent turnaround, guys, from almost no one getting the right answer to the majority getting the right answer. So we're on the move. Dr. Harrington, please take us through the first patient case.
Okay, so our first case will actually demonstrate this as an example. So our first patient is Ms. Wade, who's a 67-year-old African-American woman who's a retired teacher. And she had a total knee done about 12 months ago. Previously, she had lost weight to become optimized for surgery. She had had 17 years of arthritic symptoms and decreased function. And so, 1 year post-op, she comes in now with continued pain and swelling and some stiffness and difficulty walking. And so she's done okay following her surgery, but really not had the ideal functional outcome that she would have liked. And she falls into the category of what we call the never catch up syndrome. And if we go to the next slide, you can see that never catch up syndrome has been described particularly for women and particularly women in underserved groups, where if you look at the typical improvement expected after surgery, that is achieved. However, because these women tend to start later and at a lower functional status, they never achieve the ultimate improvement that would be possible had they had earlier intervention. And, it's very, very common that, much more so for women than men, women tend to take care of everybody else over themselves before finally showing up at a much lower functional status. And so one of our goals is to try to get patients in to receive appropriate care, not necessarily surgery, but at least care at an earlier stage so that they can maintain and maximize their functional outcomes.
Great. Well, as we've mentioned before, disparate orthopedic joint intervention happens even when there's equal access to care. So Dr. Harrington, can we talk a bit about some of the implicit biases that surgeons may carry, like the rest of healthcare professionals and the rest of us in society? We're not necessarily immune once we put on the white coat. And how these biases may impact both patients who require necessary joint procedures and patients who receive joint replacement surgery.
I think the big challenge with bias from both surgeons as well as even primary care providers can affect who gets referred for surgical intervention in terms of thinking just the simple fact of thinking about whether the patient would be a candidate for joint replacement surgery. And then in terms of the surgeon, considering, do I want to operate on this person, and whether that is an implicit or explicit bias at play. Because again, we run into the challenge of the medical comorbidities. And as we as physicians are being more on the hook for complications with, value-based care and bundled payments, it's a significant potential disincentive to operate on patients who may be at higher risk for complications if we are not going to get reimbursed, or the institutions aren't going to be reimbursed for covering complications. So, all of those factors can play a role in who gets surgery.
One comment, so not a question, but just a comment. A provider noted that they have had patients who were told to come back when it really hurts. And so that just underscores some of the issues you were just mentioning about disparities in pain care, issues that may be underlying around reasons for not wanting to perform procedures because of possible insurance reasons and reimbursement. And so I think it's complicated.
Yeah, I think that's actually a great lead into to our next case.
Yeah, so tell us about that. So this patient is Mr. Anthony Eduardo.
Yeah, so Mr. Eduardo is a Hispanic gentleman who runs a construction company, and he's had sort of chronic back pain and hip pain for many years. And, he's on numerous medications, occasional narcotics, but has had a recent worsening of his symptoms. And, his referral to see an orthopedic surgeon to discover that, ultimately he was a candidate or needed a hip replacement was delayed. And so I think it's a good reflection of the challenges with management of musculoskeletal pain in minority patients, and that it often gets undertreated and overlooked. So if you can see in the next slide, showing that patients with multiple musculoskeletal pain in the Hispanic and African American group have later interventions for treatment of their pain again. And so, even though the burden of arthritis and degenerative joint disease is higher, the utilization of joint replacement in minority groups is lower.
That's a pretty stark graph you've just shown. It's pretty telling.
And again, it's a multifactorial issue. Some of it is certainly patient education, and even just having patients consider joint replacement. That's one of our big things.
Mm-hmm. So let's do another patient case before we transition to another topic. So this is Mr. Adam Curry, and he represents younger adults who may need orthopedic interventions for joint damage, especially for individuals with sickle cell disease, which is more common than most people are aware. I practice here on the south side of Chicago, and a fair number of our patients who are admitted to the hospital have sickle cell disease. So can you talk a little bit just about the pathogenesis behind this type of joint disease and what kind of surgical care should patients with sickle cell have?
Yeah, so, in this case, it's a young man, otherwise pretty active, with a history of sickle cell disease. And sickle cell is a common cause of avascular necrosis of the femoral head, which can necessitate total joint replacement. And, one of the challenges we see in dealing with our sickle cell patients is trying to delineate between their sickle cell crisis versus just worsening of their hip pain symptoms. And, it also leads in, as we can see on the next slide, the challenge of, again, going back to pain management in the sickle cell population of, being considered potential opioid seeking and other challenges. And so it can lead to delayed care in these cases as well.
So for this patient, it's particularly fascinating because we're at the intersection of internal medicine and orthopedic care, at the intersection of all of the reasons that we see health disparities and the challenges that people have with their with structural inequities and life burdens and the life course, intersecting with all of the existing literature about stigmatism and disparities in pain care. What can you tell us about pain care disparities, particularly in orthopedic patients? You've talked a little bit about that already, particularly through this lens. And then we had a question about not just how do providers learn more about disparities, but what can orthopedic surgeons actually do to address some of the disparities? So this is an excellent case study to just begin thinking about some of the things. Mm-hmm.
Yeah, well, this falls in line with many of I think some of the more classic disparity studies that we see about pain in terms of, inadequate analgesia in emergency departments for fracture care in Black and Hispanic patients. And, again, with the sickle cell, one of the common things I try to, delineate with my patients is sort of, is this just your hip bothering you, or is it a crisis? So if you can tell me that your sickle cell's otherwise, reasonably well controlled and your hip is killing you when you're not having a crisis, okay, then we can, work on the hip. If if they come in and their hip's just hurting every time they have a crisis, then we need to work on, getting the sickle cell disease under control. But, that takes a lot of time and discussion and, sometimes a little while to try to figure out and to manage appropriately. And also, co-management with the primary care or other medical providers.
Mm-hmm. Yes. So that leads us directly into our second learning objective, our call to action, implementation strategies to improve racial equity in orthopedic arthroplasty and surgical care. And so before we dive in, we have another audience response question. And so this one is specifically about addressing surgeon biases to improve disparities in orthopedic joint care. And so these should include, number one, mitigating medical myths and stereotypes. Number two, patient translators in all surgical consultations. Number three, patient weight loss and nutrition counseling. Number four, implementing the most up-to-date surgical procedures for joint replacement. And always number five, I have no idea. I'm not sure. And so we'll give a few minutes for everyone to clock in their answers. All right. Once again, you guys are doing great. So 65% answered mitigating medical myths and stereotypes, and that is the correct answer. So Dr. Harrington, we've mentioned surgeon as well as healthcare provider and general biases above. And how does this impact patient care in orthopedic surgery? And again, how can we begin to address this?
And so again, I think one of the big things is awareness. And I know the data is is mixed out there on whether or not unconscious bias training or cultural humility training works or not, or worsens stereotyping or what. But I think it's something that people just need to be aware of so that they can address to deal with it if they so choose. I'm sure there are some folks who don't care to address that, but it's one of those things that just in terms of trying to treat the patients, a good quote that one of my colleagues, Dr. Valerie Lewis, who's an orthopedic oncologist and chair at MD Anderson, has said, and I'm sure I'm going to misquote it, so I apologize, Val, but sometimes to treat patients equally, you have to treat them differently. And one of the common things that we hear in some of our diversity trainings and things is, oh, well, I treat all my patients the same. And that does not address the social determinants of health and all of the other issues that can lead to disparities. And so, I think trying to get patients to realize that the same is not necessarily equal is a challenge.
Yes, I think the way that I sometimes talk about this is what we're already doing in clinical medicine when we think about risk adjustment. And so when we think about our high risk patients who, are high risk for having a heart attack, well, we give them a statin and an aspirin. If we think about people who are high risk for, cardiovascular events, pre-op, we'll put them on a beta blocker. And so there are certain patients that are going to be high risk for poor health outcomes because of social determinants of health. And so we need to give them additional resources to decrease those risks of poor health outcomes. And so it's the same paradigm. People who are at increased risk need additional things in order to have, to reduce that risk of poor health. And so it's just a different way of thinking about the intervention. There's not a pill for injustice, but the intervention can be things like, intensive case management. And we're now getting into the area of thinking about addressing things like housing insecurity and food insecurity, because we know how important those are to long-term maintained and sustained health. And so if we just take the models that we already know about health and well-being and expand those outside the box to think about non-medical therapies, then we can easily fit into that paradigm ways to improve the health for vulnerable populations as well. So I'm going to tack a little differently now and move from thinking about disparities in health outcomes to diversity, to related but different fields. So we know from the data that orthopedic surgery is among one of the fields that has the least diversity for surgeons, faculty, and residents.
You're number one.
They want to put you on blast. But I will say that I led a study a few years ago looking at organizations and what they were doing to address disparities in diversity. And I was shocked, actually, how much orthopedics as a field and as an organization, organizations was doing a lot to enhance diversity. And I suppose maybe because you guys had been number one or at the bottom of the barrel. Yeah, a lot of, all these programs. And mom's like, what is going on with orthopedic surgery? They really got their game together. But talk about why having diversity among healthcare professional matters.
Well, I think, there have been studies that show that racial and ethnic concordance leads to better clinical outcomes, better communication, which I think is the critical thing across the board, whether it's surgical or non-surgical, to optimize outcomes. And so, it is an area that within orthopedics, we've got several organizations that have done quite a bit of work, and we're slowly making progress. I think part of our challenge is now just getting more underrepresented minorities through medical school. Our big challenge is that we've got a handful of great students, but it's only a handful. So all of our programs are competing for the same small number of people. And so we just need a bigger pool. In orthopedics, we also are not very gender diverse, but I think that's a different issue because, there are plenty of women to choose from. There are more women in med school these days, but, we've just got to figure out how to get them into orthopedics versus, well, we still only have a tiny percentage of underrepresented minorities. So, all of our specialties are fighting for that small group of applicants.
Mm-hmm. Absolutely. We talk a lot about having a very leaky pipeline, and that pipeline starts, so early in our school systems. Mm-hmm. And the Pew did a study in 2017 and found that our public school systems are still as segregated and unequal as they were back in 1953. And so the vast majority of Black children and children of color are still being educated in public school systems that are wildly under-resourced, where the vast majority of kids are extremely low income and have concentrations of persons of color, and where the schools are very under-resourced. And so they're not getting the same tools and, bells and whistles and teacher ratios and all of the things that they need to be successful to sort of push their way through the pipeline. And that has not changed significantly since, Brown versus Board of Education. So we've got a lot of work cut out for us still. So I'm going to loop back to another issue that we've been talking a lot about, which is how we as healthcare professionals cannot just think about diversity within our own profession, but begin addressing other obstacles to equitable surgical care, such as these social and structural determinants of health that we've been talking about, and structural or institutional racism. So can you talk a bit about that?
Yeah, so, on the ground level, it's something that I, try to address more and more and think about more and more every day when I'm just in dealing with my patients, really because of the outcomes and, because of our, current protocols and processes of, getting patients in and out of the hospital quicker, or not even in the hospital doing surgeries on an outpatient basis. And, one of the big things to focus on is what are the patient's resources in terms of even thinking about scheduling surgery. The big challenge I have is, finding folks who have support at home so that they can go home as opposed to a skilled nursing facility. Mm-hmm. It was interesting being here in Houston, where most things are on a single level. I was talking with a colleague who was in New York, and I was amazed at the number of patients there that they send to skilled nursing facilities or rehab facilities. And, he pointed out that, a good number of those folks live in 4- and 5-story walk-ups. And so they aren't able to go home, whereas, here everybody's going to a little ranch or bungalow or single level. But, and just simple things like that of, okay, well, why didn't you make it to physical therapy? Well, my son couldn't take off work to take me. Yes. Or if they did take off work, they're going to get fired. And so all of those things that you may not just think about routinely when you're scheduling someone for surgery, and you say, oh yeah, we send you home the next day, and then you go to outpatient physical therapy and you do this, that, or the other, whatever your protocol is. If you don't consider, the patient's resources and social situation, you can, be surprised in the end when your outcomes may not be what you want. Exactly.
We have to look more deeply at what appears to be race neutral policies and see how they can have a differential impact on society in a way that disproportionately impacts those that are vulnerable, those that are poor, racial minorities, because of the resources it takes to implement those race neutral policies. And that's played out a lot in the COVID pandemic, and in sort of routine care, as you just said, people who can't do same day surgery because they may not have the same social support system. And why might that be? Because everyone still has to work. There's not the intergenerational familial wealth that's been built up where people can retire earlier or have these other kinds of things. And so it's sort of built into our societal fabric so much that we don't even notice that there are differences. And so we have to think about equity on the front end. We have to plan for equity when we implement race neutral policies. Otherwise, we'll end up with inequity on the backside. So excellent conversation. Dr. Harrington, tell me more. You are on the steering committee of the Movement for Life Coalition. Tell me more about that organization and other ways that we can mitigate disparities in orthopedic joint care.
Yeah, so Movement is Life is a group. We've been around now for, 15 years. It's a multidisciplinary coalition, and our goal is to address musculoskeletal health disparities. And our focus has been on women and underrepresented minorities, focusing primarily on hip and knee pain primarily. And you can see on this slide, we started off years ago with what we called our vicious cycle. And our goal is to just show the importance of movement in terms of overall health. And, you develop the vicious cycle of lack of movement, joint pain, and it just goes round and round. And then you start to throw on the comorbidities of diabetes, obesity, heart disease. And it's just a vicious cycle of trying to get folks up and active and get rid of and trying to eliminate these disparities. And so as we've evolved over the years, we've developed community level interventions and policy level interventions, and we do have an annual caucus each year to address these issues. But one of the things, this is our original vicious cycle. We have added in a couple of extra rings lately. So there is now a ring that addresses social determinants of health and all of the different issues of, zip code and, housing, food deserts, and all of those things, which, surround all of your basic health issues as an individual. And then we've also added a policy ring of looking at healthcare policy. And, we've done work with, the late John Lewis trying to help draft legislation looking at health equity. And then this past couple of years, we added yet another ring that sort of impacted everything, which is COVID around the outside, which further shows the inequities. But Movement is Life, we've been working on multiple levels from grassroots programs called Operation Change, one of which is in Chicago, which is a local community-based program, all the way up to working with lobbyists and Congress trying to push legislation through.
I see that BMI is on that. And we had a question earlier just about addressing BMI. And is there a better way to assess that in patients with higher BMIs who may be deemed unsuitable for joint replacement surgery? And should BMI be reassessed based on body type?
That's a great question. I know there's a lot of debate about BMI, and even within the orthopedic community in terms of looking at using BMI as a weeding tool or risk stratifier, cutoffs for surgery. There have been some studies looking at sort of more fat distribution as opposed to strictly BMI and what's the limiting factor. There are also several surgeons who have excellent results even in higher BMI patients, but they are also have excellent protocols to otherwise optimize the patient in terms of nutrition and all of the other risk factors. And so In and of itself, it's it's one of many things that we use. It certainly, I know, is used to sort of do the as cherry picking and lemon dropping, as we say, to not operate on some folks in some cases. But it's the current tool that we have. And so, the biggest challenge I have is that when we do have patients who need to work on weight reduction, it can be challenging to get them into programs. A lot of times programs aren't covered by insurance. And so these folks do get caught in that vicious cycle.
Mm-hmm, mm-hmm. We've had several questions come up around shared decision-making and communication. So I am very happy that we landed to our next slide. Communication is really important in every relationship. And me as a primary care doctor know that firsthand. It's also very important for the surgeon-patient communication because people are literally putting their lives in your hands when they go under. They're unawake and a lot of times very afraid. And so they're trusting you all to do the best for them when they are not able to be awake and speak for themselves. Dr. Harrington, in your experience, how important is communication and how can we, as providers, particularly as surgeons and care professionals, improve patient-centered care and communication?
I think communication is critical to achieving outcomes. For me as a surgeon, and particularly in the realm of total joint replacement, whether it is a high-risk patient or a low-risk, active, quote, ideal patient, communication is critical so that we're all on the same page in terms of our expectations for outcomes. One of the things we see sort of more commonly in our underserved population is patients aren't aware of the successes of surgery and come in with fear. And so trying to get patients over that fear and to realize that they can have a good outcome and that they are good candidates for surgery is critical. At the opposite end of the spectrum, I get some folks who come in and, their knee hurts a little bit and they want to get back to, doing their CrossFit and running marathons and things like that. And, those folks, I have to sort of counsel the opposite way and tell them that, I may not be able to meet all of those expectations. So, I think that's critical. And then also, when it comes to the higher risk patients who may fall into the less than ideal or not ideal surgical candidate category based on their comorbidities, is how do you communicate that with them and get them on an appropriate treatment plan so that you're not just saying, in the old days, go away, come back when you've lost 100 pounds, which used to happen. And so how do you keep the patients engaged and involved in their care?
So great. One of our questions was, what are your best practices for patient-centered and care and around shared decision-making? So this next slide, I think, is right on time. Can you walk us through this?
Yeah, so I think the critical thing for shared decision-making is really to sort of addressing each patient as an individual and with what are their needs and expectations. And, it's challenging. That does take a little bit of time. And, I know there are some programs that have excellent, formalized shared decision-making pathways with, nurse navigators and others to go through full shared decision-making, formal processes. But I think each individual, it's really just a matter of sitting down, talking with the patient and, really listening to them and, coming up with a treatment plan that can, meet their goals and that, you as a provider are able to meet. The patient literacy, health literacy is always a challenge. I think we all use various brochures that are probably all written at a little bit of a too high level for a lot of our patients. But one of the things I do all the time is use models to show patients what joint replacements look like, because a lot of patients across all socioeconomic groups really have no clue what a joint replacement looks like. And the simplest thing I can do is just show them a model and let them play with it, feel it, and see what it looks like.
Right. Health literacy and literacy are not the same. And so excellent advice. I want to talk a little bit, we're running short on time, but I want to make sure we have a few questions that we answer at the end. But can you talk us through a little bit around telemedicine in orthopedic care?
Mm-hmm. Yeah, telemedicine is interesting. COVID sort of forced a lot of us to jump into the telemedicine field where we had never really used it before. I think the utilization in orthopedics has been variable from institution to institution. One of our challenges is that we are very dependent upon the physical exam for the musculoskeletal system, and then having imaging, which can be challenging to do, over telemedicine. But for post-operative visits, I think telemedicine is being utilized, and I think a lot of practices are now starting to move more and more towards using telemedicine visits for long-term follow-ups and just routine checkups where you don't necessarily need to see the patient in person.
Great. This has been wonderful. Thank you so much, Dr. Harrington, for this insightful discussion on mitigating disparities in orthopedic joint procedures and care. And to summarize this program for our listeners, our SMART goals for each of us to keep in mind are: first, to recognize and address implicit bias and discrimination, improve awareness of the impact of structural racism, and increase diversity among orthopedic surgeons. Second, to identify inequitable processes and pathways in the prevalence, treatment, and pathophysiology of musculoskeletal and degenerative joint diseases in minority populations. And last, to incorporate solutions to address racial and ethnic disparities in orthopedic joint disease and diagnosis and management to access orthopedic care. So we've received a number of questions already. You can actually keep submitting your comments and questions by clicking the Ask Question tab, or you can also email us at questions@cmeoutfitters.com or tweet to @CMEOutfitters. So we're going to take just a few questions because we've had so many and they've all been excellent. One person wanted to know, what are the most common causes of mortality after orthopedic procedures, and how can these be mitigated in underserved minority patients?
Well, fortunately, and one of the reasons I went into orthopedics is that mortality is pretty darn rare. For what I do in terms of total joint replacement, probably the most common early mortality thing that we see is from pulmonary emboli and DVTs. The other issues would be most likely just cardiac anesthesia related, which fortunately are pretty rare since we are pretty, rigorous about preoperative optimization and screening and getting, clearance from all the medical providers. And so, most of our folks that we are actually doing our elective joint replacements on are pretty darn healthy, or as healthy as we can get them before jumping into surgery.
Mm-hmm.
So, for DVT prophylaxis, everybody receives these days. I believe the majority of orthopedic surgeons are using aspirin. And probably the biggest thing is that our patients are no longer laying in bed; they're up and running around the day of surgery, and
yes, they are.
getting back going. And some of them are at home running around the day of surgery. For the other perioperative medical issues, it's truly just close medical monitoring. I think one of the areas that we're focusing a little bit more on in terms of the long-term outcomes and morbidity mortalities is actually infection. When you look at the data for the mortality after a total joint infection, it's pretty scary. And so, trying to decrease the risk of infection and other complications is really paramount.
Excellent advice. This is a comment from someone getting back to the conversation around sickle cell disease. And they noted that in practice, the advocacy of the hematologist has been enormously impactful. The hematologist who regularly refers to my surgical practice actually acts as a pain management advocate in the postoperative period, which supports the patient and mitigates bias in providers who are unaware of their underlying racial disparity leanings, and sort of levels the playing field and acts as a go-between. And we have that in our hospital. It just makes it easier for us to rely on the pain service specifically for sickle cell patients. They have a continuity of care relationship. They know all the protocols. And so that helps to decrease in disparities. One question that came up early on that is present in every podcast and every live session is, how do we best ask patients about social determinants of health? And that is for every cardiologist, every dermatologist, and now for you, the orthopedic surgeon. How do we address these issues and broach these very sensitive subjects in our patients who we know may be struggling with them, but we know that these are very private issues? How do we do that? How do you do that in your practice?
I start pretty simply, and whenever I'm scheduling somebody for surgery, I'm like, okay, so who's going to be at home to help you out afterwards? You're going to need somebody, for the first few weeks to stay with you and help you out around the house, and that's usually a good easy place for me to start. It's directly related to the surgery we're talking about, so they don't feel like it's sort of prying or intrusive, and and they can understand the rationale for the question. And then that can then sometimes lead down the path of, well, I don't have anybody with me, or my kids work, or whatever it is. Mm-hmm. I think from an orthopedic standpoint, that's probably the biggest area that we see. We don't often get into the, food insecurity and those other areas, which may certainly be relevant.
Great. So thank you again. Please join me here at CME Outfitters for our upcoming briefcases and activities with more action steps like these against health disparities. In particular, 2 of our upcoming briefcases will examine diversity and inclusivity in 2 important areas: cardiac arrhythmia and oral health. We'll be adding new content every month, and we really want to hear from you, our audience, on what you need so we can make an important impact in these important areas. You can find out about all these events that are live and view previous ones on the DNI Hub here at the link. Please remember to collect credit for this activity by using your, oh goodness, I'm having an issue with the, okay, but I'm sorry. Please remember to collect credit for this activity by using the Apply for Credit button that's here on your screen. Again, thank you so much for Dr. Harrington for your time and energy, your passion, your dedication, for all of the work that you do. Thank you so much to our audience for all the work that you all do in providing equitable and holistic care for your patients, and for sitting in for today's session. Thank you to everyone who's listening around the globe and who tunes in later. Have a wonderful day.